Good afternoon. Today I am going to speak about the hip fractures in elderly patients. As the population of the older adults increasing all over the world, so does the number of the hip fractures. Older adults have a weaker bone and more likely to have fall because of their diminished balance, multiple medications, medication side effects, difficulty in maneuvering because of the stiffness and other factors. So the increase in fall results in more hip fractures in elderly. Clinicians in many fields involved in the caring of the patients of hip fracture and should be familiar with the basic type and assessment of the management of this type of injuries. This is, I'm skipping, this is the basic anatomy of the hip. This is not required for the orthopedic surgeons gathered here. So as we all know, the basic type, intracapsular and extracapsular, since our early days of medical college. So worldwide, the total number of hip fractures is expected to surpass 6 million a year in the year 2050. Age is the main risk factor of hip fractures. The incidence of hip fracture increases exponentially with the age in both the genders. Hip fractures are estimated to be the 72% of the total cost of the fracture-related cost over the world. It is not a surgical disease. Hip fracture needs a wide multidisciplinary approach, starting from the ambulance service, emergency department, orthopedic surgeons, geriatricians, the critical care specialists, rehab specialists, end-of-life care, social services, as well as the health services in the community health service. The risk factor for hip fracture is osteoporosis. Of course, I told about falls. Female gender is more prone to have hip fractures. Low socioeconomic strata, it is seen that the hip fracture is more common in lower socioeconomic strata. The cardiovascular disease, endocrine disorders, and some medications like benzodiazepine, antidepressants, they are, because of the instability and the problem they cause, increases the fall. These are the common comorbidities. It's a busy slide, I'm keeping it, but the commonest comorbidity which is associated with the elderly people in hip fracture is hypertension, and diabetes is also very common in our day-to-day practice. The risk factors for fall, if there is a past history of fall, the chance of fall increases. So whoever has a history of fall should be aware. The lower extremity weakness for neurological and other causes, as the age increases, the chance of fall increases. Female gender is more prone to cognitive impairment, balance problem, psychotropic drug usage, multiple drug user, arthritis, previous history of stroke. This is a list of things which can increase the chance of fall, so they should be the patient with this kind of history should be very aware, very cautious about fall and related hip fractures. It has already been published with a meta-analysis in the Injury Journal 2010 that the non-operative versus operative, the hip fractures treated operatively has a better result, better outcome beyond doubt. Delay in surgery more than 48 hours in a hip fracture increases the risk of complication and corresponds to the significant decrease in 1-year survival. Preoperative assessment or consideration, extensive preoperative medical evaluation is a must. There should be a thromboembolic prophylaxis in all hip fractures. It's standardized now, and the pressure ulcer prevention is another important factor here. The patient should be transported as quickly as possible to the nearest hospital or a health facility. The pain relief should be opioid or Entonox. Entonox is not very well available in our country at least. If long journey in transportation, then patient should be considered to have a catheter. History On arrival to the hospital, history and examination is a must. Concurrent medical condition and relevant past history should be documented. The drug therapy history should be taken. Premorbid functional status and premorbid cognitive function should be assessed very thoroughly. It is for all standard fracture, hydration, nutrition, pain, core body temperature, that should be assessed. This is more of a medical issue than an orthopedic issue. If a patient lies on bed or a floor for more than 1 hour, it's a critical time. There should be thorough assessment of pressure ulcer, the chance of rhabdomyolysis, hypostatic pneumonia, hypothermia, dehydration, and even chance of death should be assessed very critically before any further management. The cause of fall, I have made a mnemonic for this. I save 2 DNA, illness, syncope, accident, visual impairment, epilepsy or other type of fits, different types of drugs like anticonvulsant, antihypertensive, etc., dementia, the other neurological issues like stroke, neuropathy, neurodegenerative disorders like Parkinsonism and etc., and anemia. So these are the cause we should remember: the high chance of fall and have hip fractures in elderly. These are immediate management: analgesia, hydration, pressure point care, immediate radiology. If there is a confusion, then we can confirm with MRI scan. Analgesia, with best thing is paracetamol, if required opioid, but NSAID should be, it can be used, but not a very good recommendation for the elderly people. Patient's relative and patient should be informed about the diagnosis, the choice of anesthesia, choice of analgesia, surgical procedure, what is in the plan, possible complication, post-operative care, rehabilitation program, the long-term outcome of the fracture type, and healthcare professional involved in it should take care of all these things. All patients presenting with a fragility fracture or hip fracture in elderly should be managed in orthopedic ward, but it should be combined with the care of the orthogeriatric specialist as well. This is worldwide recommendation, though orthogeriatric specialists are not very readily available in our setup. In our setup, simultaneous medical specialists should be involved for this particular part. Studies reported that this kind of joint venture reduces the length of stay and better outcome in long run. The aim of the operation should be within 48 hours. Chasing unrealistic medical goals should be avoided to delay the surgery. For example, it may not be appropriate to delay a surgery because of infective pulmonary condition, as real improvement is unlikely without mobilization of the patient. Hip fracture is always an urgent condition. The surgery should be urgently done, but it is not an emergency. The optimal time is 48 hours. If patient is unstable, time starts when the patient becomes medically stable or optimized. In case of a hip fracture, planned hip fracture, the last patient should go to the theatre before 5 p.m. After 5 p.m., recommendation is not to take a hip fracture, better to treat him, take him to the OR on the next day. Can cross 48 hours if it is better for the patient's medical condition. Geriatrician's cover is an international standard agreed protocol now. Surgeries should not be delayed in hip fracture patient for the antiplatelet therapy. In case of dual antiplatelet therapy, instead of spinal anesthesia, general anesthesia should be tried. It is not recommended for a planned surgery. The antiplatelet therapy should be stopped, but not for an emergency situation, and hip surgery should be considered an urgent or emergency situation, so it can be done with antiplatelet therapy as well. There is no role, it has been proven that preoperative traction doesn't improve the outcome or the benefit of the treatment anyway. Hip fracture all hip fracture surgery carries a high risk of venous thromboembolism, so mechanical and pharmacological prophylaxis of thrombosis should be undertaken. Treatment of asymptomatic bacteriuria doesn't require treatment. If it is complicated, if it is symptomatic, then it should be treated with antibiotic prior to the surgery. Anesthetics, the ideal anesthesia is usually spinal or epidural anesthesia. If it is not contraindicated, if it is contraindicated, then can be taken up under general anesthesia as well. Spinal and epidural anesthesia should be avoided in patients taking dual antiplatelet. That is the specific contraindication, because the chance of spinal hematoma, it should be avoided. This is very common photograph. We all know the intercapsular and the extracapsular fractures of the proximal femur or the hip. These are the common surgeries: the proximal femoral nail, the CCS, the sliding hip screw or the DHS, and the replacement. The protocol is for the undisplaced fracture, internal fixation in situ for displaced intercapsular fracture, closed reduction and internal fixation. There are so many varieties, I'm not going into it, but arthroplasty is the treatment of choice for older patient, biologically less fit. If less elderly and more fit, then it is THR, and if it is more elderly, less fit, then it's a hemiarthroplasty. And these are the treatment protocol for the extracapsular fractures, the sliding hip screw, PFN or long PFN. If overall medical condition allows, the mobilization should be a multidisciplinary and rehabilitation should be done within 24 hours. Wet bearing on the injured leg should be allowed unless there is concern about the very poor quality of the bone. A multidisciplinary team should be used to facilitate the rehabilitation, and initial emphasis should be taken on walking activities and activities of daily life. Young patient, we know it's with a meta-analysis, 1 year mortality after hip fracture is 35% in men and 22% in women, but it is not related to the primary hip pathology. So the take-home message is multimodal approach, early surgery, and a very quick rehab is the key to success. Thank you.